Hello, everybody. I'm Ulises Baltazar. I'm one of the vascular surgeons here at Methodist Sugar Land Hospital. I am the medical director of the newly created veno-lymphatic service in Methodist. And I want to thank all of you that are online watching or listening to this seminar. Traditionally, we used to give this seminar every January, but in the conference room here at Methodist. But now with this technology that we have currently, we can broadcast this to more people as many times as needed, reaching audience that we didn't have before. So with all that aside, let's go ahead and start. So this is going to be a brief summary of what venous insufficiency is and what I've learned throughout the years how to manage and treat this problem. There is a lot of myths around the vein treatment, and it is true that in the past 20 years it has been an abuse by certain areas of the medical field in treating these problems right and left, which makes the patients a little bit hesitant to seek for help. But I'm going to try to demystify some of the ideas that linger around about venous insufficiency during this talk. So, the cardiovascular system, the circulatory system is composed of different areas. The heart obviously is the pump that actually is going to make the blood circulate throughout the body. The arteries is the ducts that are going to carry the blood throughout the body. And that reaches all the way to the muscles in the legs specifically, which act as a pump. Every time we walk, the calf muscles propels the blood back to the heart. So to speak, the calf muscles are the heart of the venous side of the circulation. The veins bring the blood back and to the heart to complete the circle. And recently, for the past 10, 15 years, has been this movement to integrate into the circulatory system the lymphatic vessels, which will be a subject of another talk in the near future. So as I was saying, it's a circle. It's a circle, and that's why it's called circulation, because it is, I'm sorry, I went too fast here. It's a circle, and that starts with the arterial side, as we can see here in the heart, that the heart pumps the blood from the red side, goes all the way to the body, delivering oxygen and nutrients, and comes back through the veins to the right side of the heart that is blue, which then in turn goes to the lungs to oxygenate the blood and recharge with oxygen so it can be brought back to the left side, completing the circle. So circulatory system is because circle. And as I was mentioning earlier, the legs are the pump of the venous side of the system. And in this graphic here, we can see how the veins on the far left of your screen, you can see the drawing of the venous system in the calf, and how is in between the calf muscles that when they are relaxed, the veins engorge with the blood that is coming back from the foot, and then when the calves contract, squeeze that blood and goes back to the heart, because we have one-way valves also that are key component of the venous return. These valves allow the blood to go in one direction and one direction only, that is back to the heart. So when the calf contracts, then we have this pump action that returns the blood back to the main circulation, the central circulation. This is a movie in a cadaver, of course, of a valve, a venous valve that is irrigated with saline solution. That's what is clear, obviously. And we can see how the leaflets open in one direction, allow the blood to go back to the heart. And when the blood wants to return, obviously, the leaflets close, avoiding the reflux into the lower part of the system that it shouldn't be there. But what exactly happens when any of these valves get traumatized? Let's say a blood clot that is going to produce local inflammation, and maybe those leaflets that you see there flapping free when the fluid passes are going to get stuck to the wall and allow the blood to go back, like we see in this graphic. You see the leaflets are virtually destroyed, and there is no function, no valvular function, which obviously let the blood go back to the legs. So that blood that is going back to the lower leg shouldn't be there, and start causing some distension of the veins, the veins engorge, and therefore can be triggering the first symptoms of venous insufficiency that we'll see in a minute. So just definition-wise, we have, you might have heard different ways to call this problem: venous insufficiency, venous incompetence, venous reflux, or varicose veins. All of them are the same. Patients get confused, obviously, because it's not their field. When the physician said, well, when you have venous insufficiency, then go with another doctor, venous incompetence, and they may think that there are two different things when in fact is the same disease. So we are not going to get into much numbers here, but I can tell you that excuse me, that the prevalence of this disease in the United States is significant. These numbers are from 2007, in which about 5% of the population in the United States was affected, about 15 million people. And it obviously is more common in females than in males for different reasons, hormonal for once, and pregnancies, obviously, when there is some increase in the size in the abdomen when women are pregnant, that puts pressure on the venous return and the pelvic area in forcing or straining the valves, and that can trigger venous insufficiency. The older the patient, or the more risk the patient has of developing venous insufficiency in varicose veins, of course. A question that is always asked, at least in my practice: what causes this? The truth of the matter is that it's a combination of different factors, of which the most important and the heaviest determining the presentation of varicose veins is genetics. Different studies in different levels have demonstrated that when a single parent has a history of varicose veins in their family, the patient has anywhere between 20 to 50% chances of developing varicose veins. And when both parents have history of varicose veins in their family, it can reach 90%. So genetics is by far the heaviest player in producing venous insufficiency and therefore varicose veins. Age, as I mentioned earlier, obviously is the older the patient, the more risk of develop varicose veins, because the reality is we are aging, period, and our tissues get softer, they are not as strong as before, and the valves may not work as good as before producing varicosities. Pregnancies: the more pregnancies the patient had, the more risk to develop varicose veins. Is being determined that 3 or more pregnancies is a significant risk of venous insufficiency. Obesity: no question, with this epidemic that we have, at least in the United States, of obesity, anything that puts pressure to the blood return to the heart is going to be a significant factor of determining the presence of varicose veins. Normally, the BMI, that is in standard measurement that we use to determine how obese a patient is. Some people agree, some people don't, but it's what we use. When it's more than 30, is significant for venous insufficiency. Previous history of blood clots. We saw the clip that I mentioned, I showed you earlier, of the valve being destroyed by a previous blood clot. Obviously, that valve is not going to work. It's going to allow the blood to flow in both ways. And when it goes back to the lowest point of the leg, it will cause distension and therefore varicose veins. And lastly, lifestyle. People that sit or stand for long periods of time are at risk of developing varicose veins. All the teachers, tailors, nurses, doctors, definitely they will increase the chance of developing this problem. The other thing is, what is a varicose vein? What is a spider vein, etc.? These pictures here of this in this slide are showing true varicose veins that are large rope-like structures under the skin that you can see and feel very easily, and they become painful because stretch the skin basically, and that stretches the nerve receptors that will trigger the pain sensation. The other problem that patients come often is spider veins. These are small varicose veins that are embedded within the skin layers. So that is important because we cannot cut them out, we cannot excise them, and present different risks. Number one is pain. Obviously, with these little veins stretched within the skin, within the layers of the skin, are going to stimulate the pain receptors and therefore can cause pain, sharp burning pain in occasions. And also, it can bleed because the layer that keeps the vein intact from the outside is getting thinner and thinner, and they can bleed for sure. Interestingly, they bleed most commonly when patients are in the shower because the skin is macerated and also because the veins dilate with warm water. This is another picture of spider veins. This actually is a combination of small varicose veins, which we can see at the distal part of the thigh, and then the dark area at the knee level are the reticular veins or varicose veins, spider veins. And all these can cause, obviously, the most dreaded complication, one of the most dreaded complications that are venous stasis ulcers, like this one. When the blood stays low in the leg for extended period of time because it cannot get out because the valves are not working, the blood itself starts decomposing. And one of the components is hemoglobin, as you know, and that is going to break down in hemosiderin. Hemosiderin then perfuses through the veins and goes to the tissues. And hemosiderin is what gives that brownish discoloration that some people have in their ankles. And it's been proven that hemosiderin stops the oxygen exchange at cellular level in this area. And if there is no oxygen exchange, no nutrient exchange, then the cells cannot reproduce. And obviously, the ulcer presents because the skin starts breaking down. So this is one of the dreaded complications of venous insufficiency, venous stasis ulcers. Now, fortunately, it's not as common as people may think, but nevertheless, you don't want to get into this scenario. What are the symptoms of venous insufficiency? Well, in general, they are classified in two levels. One is a mild venous insufficiency when patients have heaviness and aching sensation that is mostly in the evenings. In the morning, these patients the legs are normal. They don't feel heavy, aching, or dragging, etc., fatigue. In the morning, they wake up with the legs virtually normal. And as the day progresses, start developing these symptoms because the reflux, when we are upright, when we are standing, is where the blood is going to go back to the lowest point and therefore cause all these symptoms. Tightness is important because the increase in the volume that is trapped, so to speak, in the veins is going to give the sensation of tightness. Itching is common. And leg cramps at night in the calves is also common, and people don't realize that it's directly related to this. And the explanation is relatively simple. You know, if you stand all day long and the blood keeps refluxing into the lowest part of the leg, eventually the stents stretch the muscle all day long, and then when you get home and you are ready to go to bed, you are already supine, and the blood starts draining from this area, the muscles are going to relax. And what happens when you hold the muscle, let's say in your arm for long periods of time, and then relax, start contracting, and eventually triggers a cramp. And the last part of this mild venous insufficiency is visible varicose veins, like we show earlier in the pictures. From there, you go to most advanced venous insufficiency. That is all those symptoms that we spoke earlier, but also swelling of the lower leg. You start having visible swelling when standing for long periods of time that typically starts at the ankle level, and as this worsens can reach all the way to below the knee. These patients come and mention to us that at the end of the day they can see the mark that the socks leave in their legs, and is significant. That obviously is swelling. If the blood stays there, as I mentioned earlier, start decomposing from hemoglobin to hemosiderin, and that is going to cause skin color changes in brownish tones there. That eventually will bring us to the last part, the last part that is venous stasis ulcers. So those are the two. Obviously, there is more detailed symptoms that we look as a physicians with this problem presents, but that doesn't pertain to this talk because it's general information. What are the risks to not treat this problem? Is another question that I've been asked frequently. And this is important that patients understand the risk, not because it needs to be a factor of making the decisions, rather because they need to have the whole information to reach a decision if they're going to get treated or not. The first risk is that they can develop chronic swelling that is not going to go away. Typically in the beginning of venous insufficiency, as I mentioned, the swelling of the legs occurs during the day as the patient stands for long periods of time. At night, because the patient is supine, all that fluid drains, and in the morning, the legs are normal. Well, it can reach a point that swelling is not going to go away. And that is a problem because we are beyond, let's say, the reversible stage of venous insufficiency in which the swelling can be totally controlled. The other risk is called lymphedema. And I'm going to touch this briefly. I don't want to drag too much into this because, as I mentioned earlier, lymphatics is another whole topic that will require a different presentation. But just in general, for you guys to have a picture, when the blood reaches the extremities, or for this matter, any part of the body, through the arteries, is going to return to the veins. But it's important to understand that it's not 1-to-1 ratio. Not all the blood that is going to go into the limb, into the leg, let's say, is not going to come back through the veins. There is a certain amount, some people have calculated about 10% is going to stay behind in the tissues. And there is no way that fluid is going to go back in the veins. So the lymphatic vessels is another set of tiny tubes that we have within the tissues that are going to bring back that extra fluid that stays behind. Those tiny tubes, those lymphatic vessels that are there are very, very small and very flimsy, fragile, that when they are pushed by other structure, in this case, swelling from the veins, it can compromise those lymphatic vessels and they can develop scar tissue and be closed permanently. And that 10% of fluid that was brought back by the lymphatics is not anymore, and therefore will cause lymphedema. So that's a very complex disease that has no cure and definitely can be triggered by chronic edema for any other reasons. Blood clots is another risk of not treating the veins. The veins, as you saw there, as they become varicose, they become very twisted, very convoluted, and the blood that flows through those veins doesn't flow in a very organized way. So it's tumbling around within the vessel, and that can cause small blood clots that eventually can become large and can be a problem. And the last complication is venous stasis ulcers that you saw there after the hemoglobin breaks down into hemosiderin, then stops the oxygen from exchanging at the skin level, and the skin breaks down and you develop ulcers. Now, the truth of the matter, and this is very important, is that all these risks are in the minority of the patients. Not because you have venous insufficiency, you are guaranteed that you're going to have any of these problems. In reality, we are managing a number between 20 and 25% of the patients. In some papers, they quote lower numbers that will develop these complications. The problem is that we don't know which patient is going to stay just with venous insufficiency with no further damage and which ones are going to develop any of these problems. So I hope that is, clears some of the questions about the risks of not treating these problems. So treatment. Let's go one step at a time here because this is going to be a very, very touchy subject. I can see it coming because compression stockings. So compression stockings on their own, and we'll talk about that in a minute, the type of compressions, etc. But compression stockings on their own are a treatment, period, because they are mechanically, they are going to force the blood to leave the leg, irregardless the valve status or the patient position, if he's standing or supine, whatever. The compressions are going to mechanically force the blood out of the leg and return it to the central circulation. In a topic apart, let's forget about the compressions for a second. The other treatments, the other purpose of all the treatments is eliminate the incompetent veins, period. Okay, that's the objective. So now, how do we eliminate or get rid of those incompetent veins? Well, those several options are the one listed there, and we're going to visit each one. So you have a comprehensive way to see all of them and make the best decision for you. Traditionally, the oldest available technique that we have had for more than 100 years is the stripping of the vein. And that is done, we're going to go there in a minute, but the stripping is removing the superficial vein and just leave it like that. We are going to go into that topic in a minute. For the past 25 plus years, another technique has been considered now almost standard of care, and is venous ablation. Instead of removing that superficial vein, we go inside with different techniques and we burn that vein with laser. Leave it there and the body will reabsorb it. And it is 97% effective when it can be done in patients that are compliant. Is almost as effective as the stripping. Now, another way to close these veins are the following three alternatives. The sclerotherapy, that we can inject foam instead of burning with laser. We can put a catheter that vibrates and delivers the chemical without the vein. That is the MOCA technique. We can use glue, Venocil, that is the youngest of all these alternatives, being approved about 3 or 4 years ago by the FDA. By the way, all these techniques are FDA approved. They are not experimental. And as I said, we are going to visit one of them. Compression stockings is probably the most controversial topic that we discuss with our patients because there are several things that we need to know. First of all, there are different pressures, okay? Not all compressions are the same. And this is just a quick summary of the levels of pressure and the indications for them. So the white compression stockings that some of you might have in the hospital when you had any other surgery or whatever, they put in your legs, there are 8 to 15. And they are anti-embolic. That means they are just trying to prevent any blood clots. It's not really much of the, let's say, treatment for swelling or varicose veins. It's just try to stimulate the blood flow out of the legs in order to prevent blood clots. Then we go to 16 to 20 millimeters of mercury. This is considered therapeutic or for treatment. It's class 1. And that is for small varicose veins, fatigue legs, no swelling or minimum swelling, and use obviously during the day when the patients are upright and the blood might be refluxing into the lowest part. When we have patients with more severe edema that reaches all the way to below the knee, with larger veins under the skin, fatigue legs, etc., history of blood clots or whatever, then we can go to the next, the class 2, that is 20 to 30 millimeters of mercury. And thereon, the 30 to 40, which we are talking about venous ulcerations, lymphedema, and can exceed the 50 millimeters of mercury. Now, I do want to point one thing, that we physicians are at fault here, because it's very easy to prescribe 20 to 30 or 30 to 40 millimeters of mercury compression stocking to a 75-year-old patient with arthritis, just because it's what the book says, because it's what the math comes to. If the pressure inside the leg, if the pressure of the veins is this, we need this pressure outside to force the blood. That is nice and dandy, but there is no way that patient is going to be able to put the compression stocking. So what good is that going to do? Not much. That is a very, very important topic that we as a physician need to find alternatives and sit and discuss what could be a solution for that. Because on top of that, let me break news to you that compression stockings are for life. And we'll go over that in a minute. That's another myth. People think that after they have laser surgery, NASA space lab technology, Star Wars access, the veins are going to be gone. That's a lie. The maintenance is key. And sadly, the only tool or resource that we have to maintain the results that we obtain with any procedure is wearing compression stockings regularly, and we'll go over that again. So there are different lengths of the compression stockings, below the knee, all the way to the thigh, and pantyhose. So by far, the most common place in which the valve is letting the blood go back to the leg is in the groin. So please tell me, what good is that going to do in knee high when the problem is all the way to the groin? We always recommend thigh highs for different reasons. Number one is, I just mentioned the location of the valve that might be letting the blood go back to the leg. Second, when you use pressures above 20 millimeters of mercury, that compression at the knee level is gonna compress, is gonna cinch right behind the knee, like a tourniquet effect, and that's very uncomfortable for the patients. And actually, that's one of the factors that make the patients less compliant. Obviously, the compression stockings are, let's say, not the most fashionable part of the wardrobe of a lady, but let alone if it's painful. So it's important to make it as comfortable as possible. That's why I almost all the time recommend thigh highs. The pantyhose are for patients that maybe the thighs are a little bit larger and the compression stockings keeps rolling down. That is very annoying, and obviously that patient is not going to be compliant. So we advise pantyhose just to avoid that, try to avoid that problem. Now, as I said, compression stockings are for life, and I'm sorry about it, but I'm going to explain to you what I think is a simple way. Like if following any laws of hydraulics in high school, if we put our finger in a garden hose, the water is going to increase the speed, but some water is not going to come out. It's going to increase the pressure within the hose. So what is going to happen after? It's going to start leaking. So if we try to do compare this with the human body, so this is a drawing of a leg where the vein, that red area is the varicose vein right in the calf, and the large blue vein is the vein that is incompetent, that is letting the blood go back to the leg. So again, that's the incompetent vein, and that's the varicose vein. So if we are going to get rid of that incompetent vein, you call it laser, stripping, glue, whatever, we are going to close that, and that is not going to allow the blood to go back anymore through that vein, and the varicose vein is going to get better. 80% of the time, they shrink enough that the patient is happy with it. But what happens to the other veins that we are assuming they are not healthy? Because remember, up to 50% of this is genetics. So we need to assume the other veins are not normal. So all the pressure that vein was managing is going to transfer to another vein. And eventually, guess what? You are going to develop another varicose vein next to it. So the only way we have to control or try to prevent this is by mechanically force this blood out of the leg, even after laser surgery. And that is achieved with compression stockings. This is the explanation why you need it. It's not that we doctors want to torture you, we want to see you miserable wearing compressions, etc. It's not that. It's that we're trying to maintain the results from the procedure the longest possible. It is important. The textbook says that you need to wear compression stockings daily for the rest of your life. that is far-fetched. I mean, it's nice and in theory, but the practice is more complex. So what I recommend my patients is during the winter or cold months here in Houston, that is basically 2 weeks, so you can wear it daily. But as soon as the weather starts warming up, my advice is to wear it as much as possible. Ideally every day, yes, but who is going to do that with 101 degrees and 95% humidity? Nobody. So if you wear it 2 or 3 days a week, 6 to 8 hours, I think it's better than no wear it at all, because eventually the veins will come back. So that is why we need compression stockings. So now the procedures, and this is another myth that I like to clarify. The general definition of the English language, stripping, is take away or remove, okay? Now, if we go to the surgical definition, stripping is remove the main superficial veins, either the long saphenous or the short saphenous. And phlebectomies is remove all small branches of the main superficial vein. And this is important for you to understand. So the action, according to the English language, is stripping, but technically speaking, is not. Stripping is done in the hospital. It cannot be done in the office, the stripping, surgically speaking, because we need to make a cut at the groin, like we see in the cartoon here, and another cut below the knee, pass a wire through the vein, and then pull the vein out. That cannot be done in the office, period. That is done in the hospital, in the OR setting, under general anesthesia. So, as I mentioned, this technique is the oldest we had to treat venous insufficiency, but it's a good surgery, but it's painful to recover because, as you may imagine, you can imagine, there is no finesse about it. When we pull that vein, all the small structures that might be attached to the vein, nerves or small vessels, come with it. So it is difficult to recover. Some people take up to 6 weeks to recover. So, but nevertheless, it's an alternative that we need to mention for you to know. So that is stripping. Now, phlebectomies is still stripping, but it's not the main vein. Stripping in the English language is remove small tiny vessels that might be bulging on the skin, and that can be done with local anesthetic in the office. So there are two different things: stripping and phlebectomies. So that is the first alternative to get rid of the vein. As I mentioned, for the past 25 plus years, somebody in France thought about, well, what happens if we put a catheter inside the vein, like you're putting an IV on your leg, and through the catheter pass a laser almost to the junction with the deep vein, and then we burn the vein. And as a result, the endovenous laser ablation was born and has wide acceptance throughout the world with excellent results when it's done correctly in the proper patients. So it's done in the office. It's an office-based procedure that the patient is awake. Takes about, from the first injection until the ablation is done, takes about anywhere between 12 and 15, 17 minutes tops. So, and the patient walks away. One of the downsides is that obviously for us to be able to burn the vein, we need to inject anesthetic throughout the thigh in order to be painless. So that might be a little bit uncomfortable for some patients, but it's not a torture. It's done every day and is well tolerated by the majority of the patients. So in the same token, in the same idea of putting an IV through the leg and close the vein, another technique was born, that is the mechanochemical ablation, or MOCA. This, instead of passing a laser throughout the vein, we put this catheter, and this catheter vibrates inside the vein, and we inject a chemical that will close the vein. And as you see that in the tip of the catheter that is vibrating, you see the white foam That is sodium tetraethyl sulfate. That is an irritant that is going to produce inflammation and therefore scar tissue, and the vein eventually will close. The advantage of this is that we don't need to inject anesthetic throughout the vein, because this is relatively painless. I mean, the patient will feel just some vibration that occasionally might have a little bit of discomfort, but is not necessary to inject anesthetic. And the time is pretty much the same, anywhere between 12 to 15, 17 minutes from we start until we're done. The other alternative is foam injection on these veins. Varicose is the brand name. This is practiced in the United States, not as wide as the laser and the MoCA, but it's another alternative that doesn't require injection of anesthetic. I personally don't do this technique. I really don't have a good reason why. I haven't embraced it as much, so I'm not going to say something that I haven't done, but I think you need to know about this alternative. And the youngest of all the techniques is glue, that is called Venous. That technique is the same. We go in through the leg, just below the knee, and we put a catheter. The image that you are looking there is a side image, like we slice the leg long ways, and you can see the catheter within the vein, and almost at the groin with the junction with the deep system. And at this point, we press with an ultrasound that white structure that you see on top of the thigh that is pressing down beside the operator's fingers is the ultrasound probe. We pressure, and then we start injecting the glue that within 3 minutes start sealing the vein, and that stays there. So again, we don't need to inject local anesthetic to do this technique because it's painless. The glue has two of the main, I won't say problems, but the situation that the patient needs to know is that the glue stays there all the time, permanently. So it's like you put an implant or a prosthetic material in the body, because the vein is not going to dissolve, it's going to stay there, but it's going to stay sealed. Some people care about that, some people don't care. So, and it might trigger some allergic reactions, although they are very rare. It can trigger allergic reactions, especially in the skin, with redness and tenderness that is managed normally with anti-inflammatories and occasionally with antibiotics, but I'm not aware of any major problems that this had generated. So those are the techniques that we have for the seal. This is a sclerotherapy. That's a different thing. That's for the spider veins that we inject. In that case, I was still injecting foam of sodium tetraethyl sulfate, and that's the treatment for the spider veins. This has been controversial in many ways. One of them is that it's normally not covered for insurance for this kind of veins. The foam, as I mentioned earlier, is covered for the larger veins with a very thin injection, but aesthetics like this is not covered by insurance. So it's something you need to be aware of that. But anyway, this what I tell my patients about treating veins, especially spider veins, are three things. Number one, is not overnight. The injection of the spider vein is going to cause inflammation that is going to make the vein look worse, tender, etc. And eventually will get better. And that eventually, we are talking about 2 or 3 months, not weeks. What you see on TV is questionable. Okay, I'm not going to start pointing fingers, but it's not true. If you pay attention, when you see all these shows that they inject the patient the varicose vein, nobody shows you the patient a day or 2 or 3 days after. They bring it back 6 months later. Pay attention, because it's a process. It's a process. We are really injuring that vein, and then your body is going to heal it. And that healing is what makes the vein collapse. So that takes time. The second thing is not 100%. You're not going to have the skin completely clean. That never happens. It's going to be other veins around that might not be treated, and they are not going to disappear. So it's not 100%. And the last one is not forever. Some veins are coming back, especially if you don't wear compression stockings. So you need to know this, because you are making an investment, and you need to know what you're going to get for your investment. And not many people will tell you this because obvious reasons. So you need to know what treating of reticular veins is about. The restrictions of the reticular veins is not sun exposure for at least month and a half, because if you expose that part of the leg to the sun, the UV rays are going to cause that this stain is going to be permanent. You might develop a stain that is not going to go away. And the other one, and that is kind of a partial contraindication, is you cannot take hot baths. Why? Because the hot water is going to dilate the veins and the veins might reopen. But other than that, it's all that I tell my patients. And also, this is not magic. There is a God and it's not me, so don't expect miracles of this. It's going to be better, but it's not magic. Now, last part that I want to talk is general information of the treating of the varicose vein. So, as you know, as we age, we might have, this is a heart, and those are the coronary arteries, the one that bring the oxygen to the heart itself to function. When any of these coronary arteries develops any blockage, then is when we have heart attacks, because the flow is cut off to that particular part of the heart, and then we have heart attacks. Why is this important in a vein seminar? Well, because I'm sure you heard about the heart bypass, the coronary bypass, and it's exactly what it is. We do bypasses from the main artery, that is the aorta, bypassing the blockages in order to keep blood flow and oxygen to the heart. What vein do you think we use to do these bypasses? The vein, the greater saphenous vein. So it's not just closing vein for closing veins. We need to see the patient as a complete the complete picture. You know, if the veins that is causing the varicose veins are incompetent, but maybe they are not that big, they haven't dilated that much, they may be useful for a heart bypass. So we need to see what is the status of the patient. If that patient has history of a coronary artery disease and venous insufficiency, but the coronary artery disease is more significant than the venous insufficiency, and the veins are not larger than 5.7, 5.8 millimeters, we might consider, using other alternatives, compression stockings, exercise, weight loss, etc., because those veins might be used in a pinch to bypass the heart. And this is a live picture of the same, the idea that that white structure is a gauze, and just north of that, you see that tubing there, that little conduit, that's the greater saphenous vein used to bypass a heart blockage. So that's something we need to take in consideration. Now, in general, when the vein is more than 6 millimeters in diameter, normally that vein is not going to be used for the heart. So, if the patient has venous insufficiency that is symptomatic, well, yeah, we can close that vein because most likely it's not going to be used. So this is a leg. You can see there the vein that we harvest, we take out from the leg, subsequently to put in the heart as a bypass, used as a conduit or a tube to bypass the blockage. So the average normal diameter of the greater saphenous vein is about 4 millimeters. I know we are not used to metric system here, but in medicine, everything is metric system, so 4 millimeters. And abnormal size, according to studies, is more than 5.5. So in my practice, when it's less than 6 millimeters in a patient that 70, 75 years old, patient with coronary artery disease, with history of heart attacks, etc., and the vein is less than 6 millimeters and the symptoms of the leg are not that significant, I will probably use alternative therapy. But that's my practice, because I like to not deprive the patient from options. Now, let me say one more thing. The fact that the greater saphenous vein are not useful to do a heart bypass doesn't mean there are no other options that we can use to do the bypass. I mean, if the patient doesn't have any greater saphenous vein, is doomed to die? No, it's not. Don't think that. There is other veins we can use. There is the radial artery for the arm that can be transposed. There are the internal mammary artery that can be transposed. There are cadaveric veins. So there is a bunch of other alternatives. But the greater saphenous is the quickest, the fastest, with the least amount of complications to obtain to do the bypass. So it's not this or die, it's not. But ideally is what we use. So there are some patients that I showed you earlier. This is a patient with a large vein in the left leg in the posterior, and this is after the treatment. We did some combined laser and vein excisions. You can see the incisions just above the knee, the popliteal fossa there. And another patient with an anterior medial branch reflux on the left leg, large varicose veins. This is after the incisions. So again, it's not 100%, but it's much better than before. And these incisions are going to, fade with time. This is a calf. This is after laser ablation. This gentleman was a manager in one of the Whataburgers around here and stood all the time, but smart man, compliant, wore his compression stockings and maintained his legs in excellent shape after we took care of those veins. Spider veins. This is what I was saying about treating spider veins is a matter of time. It's not overnight. This patient came to me with a bleeding varicose veins on her left calf, and we injected. So you see the progression. This is about 6 months later, okay? And I'm sorry, no, this is about 3 months later. And then she came, brought her husband for other reason about a year later. So it's time, slowly improving. It's not overnight and requires multiple treatments. But again, as good as that leg looks on the right slide of your screen in comparison with the left, you can see still there are veins left there. There is not 100% clearance. You need to understand that. It's not magic. You need to have realistic expectations when you're going to have sclerotherapy. That, by the way, we are diverting more and more to dermatologists for the type of practice that is developing here. This is going to be a combined treatment. You can see, I showed you this picture earlier. You can see some small varicose veins on the side of the thigh that are feeding the varicose, the spider veins right at the knee level. So these require a hybrid procedure. We remove some of the veins with phlebectomies and in the office, and we inject those veins, and that's the result. Now, you notice right there at the knee level, there is some brownish discoloration. That discoloration is not uncommon after sclerotherapy, especially in white skin. And that eventually fades. And that eventually, I'm talking about 6 to 8 months. It's not overnight neither. And this is a venous ulceration of a lady that had chronic disease. After closing the veins and doing wound care, 8 weeks later, the ulcer closed. So those are just some examples of patients that I treated. This patient is the first one that received the mechanochemical ablation in Texas. I was the first one to do it 7 years ago or so. And we closed the vein, and this was a week later, this much improvement by closing the vein. She required further treatment on those veins for different reasons, but a week, this improvement is, I believe, is remarkable, especially when there is no injection of anesthetic. So this is all that I have for you. I want to thank your the time you dedicate to this, the 20 of you that are in the log there. And I believe we have few minutes for questions. So if you have any questions, there is it. Okay, I have one here. Question: do varicose veins recur once treated? Yes, absolutely. There is no cure for varicose veins. Understand, cure means I don't need to worry about anymore. It's done. That's it. Like when we get a appendectomy and the appendix is removed, there is no other appendix. So you're done with appendectomies. It's not the case of the veins. And that is what is important to wear compression stockings, as I mentioned earlier in the talk, to maintain other veins from dilating or growing. If you have a lot of spider veins, those, varicose veins. Okay, spider veins, technically speaking, there are small varicose veins. You already have varicose veins. But yes, when you have a lot of spider veins, that can be the tip of the iceberg. You may have venous insufficiency in the deeper veins is reflected with spider veins. So if you have a lot of spider veins and you have other symptoms like heaviness of the lower legs, aching of the lower legs, swelling of the lower legs, cramps of the legs at night, etc., yes, before treating those spider veins, I think you need a venous reflux ultrasound to properly assess the deeper veins before you inject that. Because guess what? If you inject those veins without treating the deeper veins, they are going to come back before you say goodbye. Are there any prevention from varicose vein? What is another thing to okay, prevention from varicose veins. There are several issues here. We said that 50% or more is genetics, so you can't prevent, getting blonde hair because it's just genetics. No, but if you don't eat well, if you don't protect your body, yeah, your hair might change faster than you think. Same here. There are things we can control and things we cannot control. The things we can control, obviously, is weight. We need to keep our weight down. Exercise, leg elevation, wearing compression stockings. Those things are definitely things we can do to prevent or slow down the presence of varicose veins. The ones we can control, obviously, is your genetics. That rules about 50% or more of the reason why the veins present. It's mainly genetics, but the other ones that you can control by far, absolutely, you need to do it, especially if there is history of varicose veins in your family, wearing compression stockings or support hose that, if you don't have any symptoms, if you are young, if you are a nurse or a teacher that stands all the time, of course, you need to be proactive. Does protein C deficiency contribute to reticular veins? Well, all when we have protein C, is one of natural anticoagulants that we have in our body. It's not directly related to spider veins, but the anti-inflammatory effect that it might develop some, but there is no direct correlation between protein C and reticular veins. Again, protein C is a natural anticoagulant that we have along with protein S, but no. You need to analyze, you need to analyze the vein before surgery. Yes, of course. They are asking if we need to analyze the vein before surgery, of course, before we decide what type of surgery, etc. And this is very interesting, and let me expand here a little bit more. We need to see, in our legs, we have two types of veins, and I'm going to try to make it simple. One is a deep vein that travels deep in the leg, and the other one is a superficial vein, the ones we normally take care of, okay? So a venous reflux ultrasound is a must before we treat any type of varicose vein in the legs, because number one, it's going to tell us which are the veins that have the faulty valves, and number two, how severe the reflux or the faulty valves are, basically. So if we have a patient that has a deep vein that is normal, and the incompetence of the valve is just isolated to the superficial vein, treating those veins are going to have better results, of course. Now, if we have a patient that has deep venous insufficiency and superficial, treating the superficial is going to help, but the improvement is going to be limited because the deep will remain insufficient. It's going to remain incompetent, and there is no surgery for the deep system. And let me go further there. There are surgeries for the deep system, but the results are very, very poor. For somebody that is functional, that walks, that does their life normally, with the exception of some swelling of some veins, I will never recommend deep venous surgery. Don't mess with the deep system. So if we cannot operate on the deep system, just on the superficial, you may imagine that we are, let's say, correcting the problem, just half of the problem, and therefore the improvement is not going to be as significant. Why does pregnancy cause varicose veins? There's a two-answer question. Number one is the pressure that the baby is putting on the pelvis of the mother, obstructing the blood reflux back to the heart. And number two, because hormonal. The hormones, normally the hormones during pregnancy relax the tissues, relax it, including the veins, and the valves might become incompetent and let blood flow go back to the legs. That's what is important in patients, in all patients, all pregnant patients for that matter, to be proactive and wear compression stockings. Need to talk to your OB/GYN and see what they recommend. All right. Is venous ablation considered procedure? Okay, venous ablation per se is not cosmetic, because we are dealing with a large, the main superficial varicose vein that normally is covered by insurance. We need to, check some boxes. We need to go over with insurance requirements. That is obviously the consultation, the ultrasound that proves the venous insufficiency, and then we need to send a letter to approval. It's not just walk in here and have it done. Now, the spider veins, the reticular veins, those are not covered by insurance by far. That is cosmetic. All right, well, one more. Let's see, that's okay. Very good. I think we covered all the questions. I want to thank you the time. I hope this was useful. We are here at Sugar Land Methodist Hospital in MOB3, Suite 505. If we can help in any way. Thank you for your attention.